Thank you so much for everyone coming to this presentation. We're excited to have Phoenix, Jessica, and Jane from the BC Center for Disease Control and the PEEP team who are going to be presenting on perspectives on safer supply. Take it away, guys.
Thanks very much, Brittany, and I'm delighted that we're able to present to this group on perspectives of safer supply, insights from people who use substances in British Columbia. So the presentation is going to be a bit of a tag team. We're going to take it in turns to address some of the slides. You can see there that Jenny McDougall was going to present with us, but unfortunately is not able to do so, but hopefully will join us during the question time. So firstly, I'd like to hand it over to Phoenix to do acknowledgements.
Good morning, everyone. First and foremost, we would like to respectfully acknowledge that this work was conducted across the unceded, stolen, and occupied territories of more than 200 First Nations across what is known colonially as British Columbia. Specifically, the BCCDC is situated on the territory of the Musqueam, Squamish, and Tsleil-Waututh people. We are also grateful to the peer research assistants, many of whom are members of PEEP, who were very valuable in assisting us with developing the survey, the question guide, facilitating interviews and focus groups, and as well with the interpretation of the findings. And we also want to thank the participants for sharing their knowledge and insights. And as well, we must acknowledge the thousands of devastating and preventable deaths that have occurred in British Columbia due to the toxic illicit drug supply. And we want to acknowledge and give a shout out to the people that continue to suffer from the losses of their loved ones and community members, as well as those who are still suffering and struggling under the impacts of prohibition. Thank you. I'm going to pass it on to Jane.
Thanks, Phoenix. So as I mentioned today, we're going to be presenting about the study and what we found and the information contained in the report. And there's three of us presenting, but this is a much larger team, as Phoenix explained. We have no conflicts of interest, and the funders had no input into the data collection. And you can see where those the links that you can find the report and the infographic that I mentioned. Thanks. Next slide. So what this is based on is really two sources of data. One is the quantitative, the numbers that come out of the harm reduction client survey, namely the 2019 and the 2021. And that was funded by Health Canada through the Substance Use and Addiction Programme. The other source of data were qualitative interviews, and these were interviews and focus groups led by peer research assistants and the research coordinator. And this part of the study was funded by the BC Ministry of Health, the Community Crisis Innovation Fund. Next slide. And of course, I always need to say that the funders had no input into the methods or the findings or the presentation. So this is the roadmap, the overview of what we're going to be talking about. I'll discuss the background, in other words, why we did the study. Jessica will describe the methods of how we did it. And then the three of us will talk about the findings. Under each topic heading, you can see the findings are under opioid stimulants, benzodiazepines. I'll give you the numbers from the survey data, and Jessica and Phoenix will share the voices of people who use drugs to provide the context to those numbers. And then under each of the headers, we will share the recommendations that emerged. And just to keep you awake, when you see the recommendations, you'll see they're not in numerical order. They're in the order that are in the final report. So just be aware that we can actually count. And then Jessica at the end will summarize the so what, the policy and practice implications. So let's start with some of the background, and I think everybody is only too aware of the horrific and unacceptable preventable loss of lives that's occurring in BC due to the drug toxic emergency. Just to give a little bit of context, and these are slides from British Columbia, the coroner's report. In 2021 and 2022, there were well over 2,300 drug deaths, illicit drug toxicity deaths. And we can compare that to what we saw in 2000 to 2010. It's 10 times that amount. So it's a huge increase. And if we look at the number of deaths per day, we were seeing less than one per day in that period of 2000 to 2010. And we're now seeing 6 or more. Next slide. We often talk about, what is the cause? And I think everybody's aware that really it's prohibition that has led to this toxic drug emergency. But what is actually detected in people who have died, I think it's important to highlight that over 80% of people who die have fentanyl detected, and it's been over 80% since about 2017. And you can see on this graph that methamphetamine has increased. Cocaine and meth are both over 40%, and that's for 2021. Benzos increased dramatically since 2018, and it was 23% in 2021. And hence you can see that polysubstance use is common. So over to Jessica for some context.
Thanks, Jane. So I'm just going to give a little bit of context about our own safe supply and ground some of the findings we'll be talking about today. So I think, as many are aware, and as Jane was mentioning, the unregulated drug market in BC is becoming more toxic, and overdose rates continue to rise, and this is despite increasing interventions. So things like overdose prevention sites, widely accessible naloxone, OAT. And I think the main thing to highlight here is, and I think many are aware, many interventions to date have focused on responding to overdose rather than preventing overdose in the first place by addressing the illegal drug supply. And so that's sort of where the term safer supply emerged from. So this idea that it was possible to access and produce a supply of known content by regulating the production and distribution of substances. And safer supply came from community advocacy and was conceptualized by people who use drugs, and is now something that we're hearing more and more in the discourse. My cursor is not cooperating today, so thank you for being patient. So we spent a lot of time on this project with our peer advisory, sort of defining safer supply and coming to a definition that felt good to the peer advisory and the study team. And this is because there is no consensus really. So whether to include things like IOT or TIOT. And so we worked with the peer advisory and based our definition really on a report released by the Canadian Association of People Who Use Drugs in 2019, which states that safer supply refers to a legal and regulated supply of drugs with mind-body altering properties that has been accessible only through the illicit drug market. And at the time of the study, to paint a picture, give a little bit of context, the main form of safer supply that was accessible was under risk mitigation guidance or pandemic prescribing. And so what that meant was that most people could access hydromorphone, morphine. There were very few programs offering diacetylmorphine or heroin or fentanyl. And then in terms of safer supply of stimulants, what was available was Dexedrine and Ritalin, and still to date, there are no programs offering methamphetamines or cocaine. And then most were oral formulations with very few offering injectable options and then offering inhalable options. And I'll pass it to Phoenix.
So just a little bit about the background and the rationale of the study. So primarily it was informed by evidence from administrative data such as coroners, ambulance service, and drug toxicology data, as well as research findings from client surveys and a couple of other research projects. As well, people such as myself who use drugs provided input at all stages. As a member of the peer advisory committee, as well as a trained and experienced mixed methods researcher, I personally was engaged in the project at all phases, from start to finish, including data analysis and interpretation of findings. And I really was able to feel that this was a much more meaningful partnership methodology than most other tokenizing, like surface levels of peer engagement models that is used in most research. You can see from the infographic here, which is also in our report, all of this data was used to paint the picture of what we wanted to learn and our concerns and priorities of what we were looking to learn from the study. So, and I'm going to pass it back to you, Jessica.
Thanks, Phoenix. So our study aims were really based on these 4 research questions you see here. So if people who use opioids and or stimulants were prescribed a continuous supply of pharmaceutical grade alternatives, which ones would they choose and why? How would people choose to use their preferred pharmaceutical alternative and why? So mode of use. What are people's experiences with concurrent substance use, and what substances do they use concurrently and why? And as roughly half of illegal opioids currently contain benzodiazepine-like substances, and this was at the time of the study, are there concerns about benzodiazepine withdrawal upon a potential transition to safer supply and or opioid agonist therapy or treatment, sorry. And one thing to note, so we will share some findings on models. And so beyond the substances and modes of use people were interested in for safer supply, what models would make it most accessible. So things like staffing and like requirements, take-home doses, but that was not the central focus of this study. We did share some data with Dr. Bernie Pauly and her team who are doing work on safer supply models. And so our work was really focused on the substances and the modes of use that would make safer supply meet the needs and be accessible to people who use drugs. So going over the methods, like Jane mentioned, this was a mixed method study. So for the quantitative, we relied on the harm reduction client survey, which is a cross-sectional survey, which has been administered throughout BC mostly every year since 2012. And the data we'll be sharing today comes from the 2019 survey and the 2021 survey. Some questions on both surveys are similar, and then there are some differences because the harm reduction client survey is sort of always evolving to add questions based on needs and what's going on in the province. And the analyses that were conducted were descriptive and multivariate logistic regressions to understand preferences and associations. In terms of the qualitative, so we did a mix of one-on-one interviews and focus groups. So 47 one-on-one interviews and 6 focus groups with people across BC. And peer research assistants. So not only were they involved in informing what questions we were asking, but peer research assistants actually facilitated the interviews. And for the focus groups, it was typically co-facilitated between myself and a peer research assistant that traveled across the province. And we conducted thematic analyses in vivo to identify patterns and relationships. And again, the peer advisory was reviewing the coding framework, themes and sub-themes, choosing quotes. So we're really involved throughout that qualitative analysis. And you'll see quotes throughout the presentation. There's a name, it's a pseudonym. So we've assigned a fake name to anonymize the participant, but also recognize that it's a person and not someone with a participant ID. And I'll pass it to Jane.
Now I'll start with the first subheader, as you saw from the roadmap, was around opioid preference. So the data from the 2019 survey obviously was before safer supply was prescribed safer supply was beginning to be made available, and also before COVID. But I think it's interesting to see when we ask the question, if you use down or opioids, what would you prefer to use? And 58% said that they would prefer diacetylmorphine or heroin, but a third still preferred fentanyl. What we noted was that the preference for heroin increased with age. So those who were less than 30, 55% said they preferred heroin. People who were 50 and older, 83% preferred heroin. When in the 2021 survey, the question was around, if you had a choice, what would you have? Opioid agonist therapy and or safe supply of opioids. There we heard that 47%, almost half, preferred heroin, and almost a quarter preferred fentanyl. And again, there were differences between geographic regions and gender and sexual orientation. Next slide, please. We also asked around mode of use, and in 2019, we found that over 2/3 of folks who used opioids smoked them. Of those, there was 40% who just smoked and 28% that smoked and injected. People who smoked tended to be younger and used methamphetamine. In the 2021 survey, among people who indicated a preference for mode of use of safer supply of opioids. So in other words, if you were able to have safer supply, how would you like of opioids, how would you like to use it? 62% said they preferred to smoke and 20% said they preferred to inject. Next slide. Also in the 2021 survey, we asked reasons why people prefer to smoke. So this wasn't why they preferred to smoke safer supply, but why in general they preferred to smoke opioids. Almost half said it was for safety reasons, and you can see those enumerated there. There's about a quarter that said it was the effects and preference for smoking that they were interested in. So it was the actual practice of smoking that they preferred. And then there was another quarter who weren't able to inject anymore, or disliked injecting, or had never injected. So you can see this actually, the number, some people gave more than one reason, but you can see out of the percentage of reasons, half were doing it for safety purposes. So now I'm going to hand it over to Jessica, who's going to provide some of the context and the voices of people who use opioids to really support and to show how these numbers actually work in reality.
Thanks, Jane. Yeah, the qualitative really reflected some of what we were seeing in the quantitative in terms of preference for fentanyl and heroin. So when we asked people, there's an ambulance passing. When we asked people about their preference, many stated that heroin and fentanyl needed to be available in order to meet many people's needs and objectives. And so one participant said heroin and fentanyl have the strongest analgesic effect and the strongest euphoric effect. And I find that when I was prescribed Cadian and morphine, it was helpful in terms of mitigating withdrawal symptoms, but it's more of a safety or stabilizing sort of function. People shared that the current options at the time of the study under safer supply were limited and didn't reduce their reliance on the street supply either, because it wasn't the right dosage or it wasn't providing the effects they were looking for. And so one person said somebody using fentanyl trying to replace that with Dilaudid or hydromorph, they're using their whole supply in the morning and they're screwed by noon. So really showing that it wasn't even really meeting that person's base need. And so going back to the illicit supply, they're still at risk of overdose. The qualitative data also allowed us to get some insights into why people had certain preferences. So as we saw with the quantitative, heroin was the most preferred, followed by fentanyl. And when we dug deeper in the interviews and focus groups, it became really clear that people are really intentional about the substances they use, and to increase their well-being and functionality and different aspects of their life. And so people who were interested in a safer supply of heroin, many talked about heroin being having longer lasting effects, so a longer lasting high, having fewer undesirable side effects compared to other opioids. So some people shared that they were really sick on other opioids and weren't on heroin, that heroin provided behavioral effects that they preferred. So they were higher functioning, less sleepy, and then unique euphoric properties. So participant from focus group 3 said heroin, you can do a little bit of heroin and get lots of energy, you can work a job. If you're just going to do fentanyl, then you're going to have to be willing to do what you have to do to get money every 10 minutes. So really speaking to how long the effects last, and also those physiological effects. For people who preferred a safer supply of fentanyl, again, there were unique reasons. And so some of these participants talked about fentanyl providing better pain management compared to heroin. So some people who had a preference for fentanyl for safer supply also disclosed having pain conditions that they were managing. And then there were concerns that heroin was not strong enough given people's increased tolerance from fentanyl use. And also for some, fentanyl was just familiar. So some had actually never used pure heroin or couldn't remember a time that they had used it. So one participant shared, heroin's not the biggest pain medication where fentanyl is. You can use more heroin where fentanyl, if you get a good, decent supply, your snaps fingers out of bed just like that and whistling and doing dishes. So from these findings, these were some of the recommendations included in the report that are associated with findings. And like Jane said, they're in order of what's in the report, but the first being the recommendation to include diacetylmorphine heroin in the safer supply policy directive and implement and expand safer supply programs offering heroin. Safer supply programs should also offer various forms of fentanyl, including fentanyl powder. So fentanyl powder was the most preferred when we looked at different formulations of fentanyl, making injectable alternatives to oral forms of safe supply available, and making inhalable forms of heroin and fentanyl as well as other safer supply options available. So yeah, these, and like we mentioned at the beginning of the study, these were all options that were limited in the current safe supply context. So there weren't very many programs offering heroin and fentanyl, and none offering inhalable options, and very few offering injectable options. And I'll pass it back to Jane.
Well, I've unmuted myself. Moving on to the stimulants, I think people are aware of how the use of methamphetamine has increased dramatically. And in the past 2 surveys, 2019 and 2021, 72% of participants said that they used methamphetamine. And you can see the black is crack cocaine, and that's halved, and also that the cocaine powder has decreased as well. And we've done studies and asked people within the survey why people are using methamphetamine and using stimulants with opioids. And again, often it's for safety and for the effect that it has. Next slide. When we asked in the survey what their preferred stimulant was, 59% said they would prefer to have methamphetamine. About a quarter said they would prefer cocaine. Of those, 13% were crack and 12% were powder, so it was sort of half and half equally. Just 11% said that they would like a prescribed oral stimulant, so that's Dexedrine and Ritalin. So that's what was available, but obviously the vast majority preferred other substances. When we looked at why people preferred methamphetamine as a safer supply stimulant compared to other stimulants, we found the preference was higher in those that were younger, in cis men versus cis women, and frequent drug use. This was one of the highest findings we found, that those who use drugs every day were 15 times more likely than those who use drugs a few times a month to prefer methamphetamine over other stimulants. So now I'm going to hand it over to Phoenix to provide some voices from people who use drugs.
So in terms of why people were reporting stimulant use, a lot of folks were reporting that they were self-medicating to improve daily functioning, to provide energy and productivity, and to manage physical, cognitive, and mental health related disabilities such as pain, ADHD, and other mental health issues. So one participant from a focus group said that I know because of my illness, I lack energy a lot of times. So when I used to smoke the crystal meth or the crack, I would have the energy to do the things that I couldn't do normally. A number of people who were reporting the self-medication as a reason for using stimulants said that prescribed stimulants such as Dexedrine or Ritalin were not comparable to the stimulants that they were able to source from the illegal supply and didn't provide the effects that they were seeking. As well, stimulants are used by a lot of people to address some of the effects of fentanyl. So there's a perception of safety when you are using stimulants with fentanyl that, you know, it would prevent or reduce the risk of opioid OD, extend the period of well-being, like make you feel better for longer. As a cost-saving measure to balance or level out, you know, you get too low, you want to go up a little bit, you get too high, you want to go down a little bit. So one participant from the focus group said that when you got your upper and it keeps you up and you have that mellow feeling, the body pain goes away when I mix it with the down. So it's really just repeating and kind of backing up and highlighting the findings that we've had, that people have many, many different reasons for using these drugs and using them so concurrently. Next slide, please. Some of the folks who preferred Dexedrine or Ritalin continued to use illegal stimulants as access to prescribed stimulants was restricted by prescribers. So for instance, somebody who would have been seeking stimulants for ADHD or another mental health condition would be blocked from seeking that same stimulant for treatment for safe supply. One participant said that they were on Dexedrine and Ritalin their whole life, but they wouldn't put me back on again, but they need it. But apparently I'm going schizophrenic because I smoked too much meth, but the prescriber said no to multiple clients. So that quote is a little bit, you know, basically the participant was seeking the prescribed stimulants to reduce their reliance on the illicit market for methamphetamine, and the doctor was refusing many participants for that, or many patients for that reason. As well, different stimulants have different effects. People experience the same stimulant in different ways. So people were looking for the drugs that they wanted based on the effects that they wanted. When it comes to cocaine, I want cocaine right now. I don't want no prescribed alternative. And there is no prescribed alternative for cocaine. Current stimulant use may also reflect the availability and cost for folks who are using cocaine or crack in the past. If their use has gone up and they can't sustain or afford that habit anymore, they may switch to meth. It may not be necessarily a preference, but you know, the cocaine would be preferred over meth if the quality was what it used to be and was affordable. So there's really a cost benefit analysis going on here for folks that are using stimulants. Next slide, please. As well, the current prescribed stimulant alternatives are only offered in oral forms. And this is leaving a lot of people out in the cold because they may be trying to inject or continuing to use from the illegal supply. As well, some people were smoking as they perceived it as more social, associated with stigma, and much easier to set up and clean up. One person said that smoking is just a quicker, easier quicker, easier method. A number of other folks mentioned that they had transitioned to smoking as they had developed issues with other modes of use, poor vein health, damaged nasal septum, and one participant said about that they had ended up having to start smoking because they just fucked up their nose so much that they literally couldn't snort anymore. So based on what we heard, we have these recommendations for stimulants and mode of use. Main one, provide a regulated supply of stimulants that people are accessing from the illegal supply, such as meth, cocaine, crack cocaine, and Dizoxin, as well as what's currently available through prescribed alternatives such as Dexedrine and Ritalin, as well as making these available in both inhalable and injectable forms. And I'm going to pass it back on to Jane.
Originally, when we were thinking of doing this project, we hadn't included benzodiazepines as a safe supply, but we heard that the prevalence of benzo-like substances in the illicit opioid supply back in 2020 was really high, and a high concern for people who used opioids and overdose prevention service staff who were seeing prolonged sedation due to the benzo in the opioid supply. And this was corroborated by various data sources, including biologic samples, so from the coroners, from hospital and life labs, and the drug samples that were tested. So we developed information sheets, both for people who use opioids, but also for healthcare providers. And a major concern was that if people transition from the illicit supply of opioids, and that may be transitioning to opioid agonist therapy or opioid safer supply, what was available, that they would go into benzo withdrawal. So we added this as something that we felt was really important to ask about when we were doing the focus groups and the interviews. So I'm now going to hand it back to Phoenix to talk about what we've heard.
The interview and focus group participants were, as well as many people on our peer advisory committee, were raising concerns about illegal opioids being contaminated with benzos and saying that they're ubiquitous in the opioid supply. One participant from Kelowna said, I would say that I also do have a benzo addiction because it's really hard to get stuff down on the streets that does not have benzos in it. And this is a very, very severe problem because there are very severe risks associated with benzodiazepine withdrawal. Once someone's dependent, there's also the danger of them quitting cold turkey, because quitting the benzos cold turkey can cause seizures. It's one of the most dangerous medications to withdraw from in a sort of unmanaged state, just to just try to do it yourself. So, not great. As well, there was an increased risk of overdose, and the sedative effects of benzos were causing people to experience memory loss, loss of consciousness, and being victimized when in these loss of consciousness states, being robbed, having physical or sexual assault perpetrated upon them. And if you do the benzos, you're out, and people can do anything with you when you're out on benzos. It's really frightening. I mean, just to take a moment here, I unfortunately personally experienced this when I was sold a down that was told to me by my supplier was not benzo positive. And I had just started a new job. I was only a week in, and I went into full benzo blackout mode and got fired right away. And I lost like 3 days. It's insane. It's like such a serious problem. That's the presentation. Many people now also have a benzodiazepine dependency, which forces them to seek out and use more illicit opioids to try and find the ones available on the street that contain a sufficient amount of benzos for them to not go into withdrawal. And so, you know, if they're transitioning, as Jane said, to a safer supply of heroin or fentanyl from safer supply that does not have that contamination, which is great, it's also going to cause problems for those people with those dependencies. So our recommendation based on findings about benzos is that safer supply programs need to include benzos, and that prescribers should consider providing a safer supply to those at risk of benzodiazepine withdrawal. or health concerns that can be addressed with benzos. Okay.
Great, thanks, Phoenix. And now back to one of the questions that we had on the 2021 survey, which was about people's access to what at the time was prescribed safer supply. And what we found was that 16.5% reported receiving a prescribed supply of opioids, stimulants, or benzos through the prescribed safer supply. And among those, 2/3 were opioids, a third it was stimulants, and about 10% received a benzo. So very few received benzos, even if they were receiving the safer supply of opioids. Compared to people who did not receive the safer supply, the recipients were more likely to both smoke and inject drugs in the last 6 months, more likely to use substances frequently, so daily, be younger, and be engaged in harm reduction services. So there was an association with receiving safer supply if people were using drug checking services, overdose prevention sites, and opioid agonist treatment. So now back to Phoenix to give us some qualitative findings.
Also, just to note on the previous slide, people that were also working in those sorts of peer-run harm reduction spaces were also being found to have greater access to the prescribed safer supply. So just beyond the need to just expand the substances and modes of use available, we really need to address what participants were saying about barriers related to prescribed safer supply, such as prescriber willingness, practices, stigma in healthcare, inadequate dosages, models and requirements for pickup and travel that are not appropriate for rural and remote communities, as well as folks with limited mobility. So really just expanding the substances, the modes of use, and just the ways in which people can access safer supply. One participant said that it depends literally where you're at in DC. If you go to a different city and be given like anything as opposed to, you know, what we have available here, and it doesn't make any sense whatsoever. And then a second participant said that I know it can be problematic when it's not reaching people, when people are not able to get into town to get on it. I'd like to see something that would be accessible. And this also included barriers related to policies around missed doses that were inflexible. People being cut off from their supply if they miss doses, other undesirable program settings and requirements like I could quite happily get heroin and carries and you wouldn't see me. I'd pick up my carries, I'd be out working, doing whatever I wanted to get out of here. Like right now, I take morphine, Dillies and diacetylmorphine and fentanyl simply because I don't want to go to the fucking clinic 3 times a day anymore. Next slide. Yeah. And then just again, some more recommendations based on our findings. We ask that those in power provide low barrier models that include virtual and mobile options, take-home dose options, flexible and appropriate policies around missed doses to ensure access to safer supply programs, as well as seeking Section 56 exemptions from the federal government to legally develop, implement, and evaluate non-prescriber safer supply models, such as the DOLPH model, which is going on here and now. Provincial governments have a role in supporting these compassion clubs and co-ops, as well as involving us. Nothing about us without us. Thank you, Jessica.
Thanks, Phoenix. So this brings us to policy and practice implications. So the so what of these findings. And I think, as we all know, safer supply and its aims will only be attained if safer supply programs are acceptable and accessible to people who use drugs, and are a true alternative, an attractive alternative to the illegal market. And what we saw from these findings is that current safe supply options aren't meeting the needs of people who use drugs for many, because, and one of the reasons being because the substances are not being offered in the right doses, are not offering the effects people are seeking, there are a range of modes of use. And so people continue to use from the illegal street supply. And I know with our qualitative findings in the pre-focus group and interview questionnaire, when we asked people what they were using, virtually everyone who was on a safe supply was also using from the illegal supply. So as our recommendations spoke to, we need, and I'll say urgently, as a caveat before saying these, with urgency, we need to expand the substances offered, so including diacetylmorphine, so heroin and fentanyl, stimulants other than dexedrine and Ritalin, so methamphetamine, cocaine, having a range of formulations and specifically inhalable formulations given our findings. And then we also need low barrier models and models that are accessible to people. So things like take home doses and exploring non-prescribed models. And I will say with the expanding substances and formulations that these are applicable to prescribed and non-prescribed programs, because regardless, we need these options. And then the last thing to note is, I think safe supply programs need to recognize that it's a really heterogeneous group, or there's different needs, different preferences. And so one size won't fit all. And that's why we need a range of options. And then also flexibility, recognizing that people's preferences and needs may change throughout their own life, but also we may see changes in trends of what people generally want and need. So for example, knowing that many are smoking primarily for safety reasons, if they had access to a safe supply, we may see changes in the mode of use they prefer, if they're not having to take that into consideration. Similarly, if many are using stimulants to balance out the effects of fentanyl, if people did have access to a safe supply of an opioid of their choice, let's say heroin, if fentanyl wasn't their preference, we may see some changes that way too. So yeah, building in that flexibility into safe supply programs. And so here are the 13 recommendations. We've gone over them throughout the presentation, and you can find them in both the report and the infographic. And that brings us to the end of the presentation. So these are references. I'll leave it here. Thank you so much for listening and for this space. Yeah, and I think we have some time for questions and a bit of a discussion.
Hi, Jessica. Thank you so much, everybody, for this really great presentation. I see that Matt already has his hand raised, so I'm going to stop recording and we can go straight into that discussion.